Good evening, everybody. Welcome to this evening episode of Pursue. And today we start with Pursue 8A, which is Nephropathology. And with us, we have to start with Dr. Suvradeep Mitra. Dr. Suvradeep Mitra is a postgraduate from PGI Chandigarh. He did his DM in Histopathology from PGI Chandigarh and had also done his PDCC in Renal and Transplant Pathology from PGI Chandigarh. Presently, he is the Assistant Professor in the Department of Pathology and Lab Medicine in All Indian Institute of Medical Sciences, Bhubaneswar. He has more than 70 publications in indexed national and international journals and 2 chapters in books. And he is an expert in nephropathology. And who better than him to start with nephropathology, a subject which is quite difficult for general residents to understand. So before we ask Dr. Suvradeep to take over, let me request everybody here, please keep your mic muted, please keep your camera off, and please do not share your screen. When you log in, please log in with join now and don't press present now. With this, I would request Dr. Suvradeep to start. Sir, please take over. Thank you.
Sir, am I audible?
Absolutely clear. Please share your screen.
Yeah. So,
yeah, we can see your screen. Yeah, please make it full screen, please.
Yeah. Is it visible, sir?
Yeah, very, very visible. Yeah, just remove that hide thing.
Yeah. Okay.
Yeah.
Okay.
Thank you so much. Yeah.
Thank you, sir. Thank you, sir, for such a kind introduction. It's really pleasant to hear it from you, who himself is a very busy and renowned pathologist. A good evening to everyone. So, I'm supposed to talk about the terminologies and approach, but I have changed it a little bit, saying it to be an introduction to nephropathology. I have made things very simple, especially for the postgraduates. Let's see how we can proceed. I put a little bit of disclaimer, and all the slides and all the images are mostly clicked by me as a practicing pathologist. And before I begin, I like to thank my mentor and my guide in PGIMER Chandigarh, from whom I have learned renal and transplant pathology, Dr. Professor Ritambra Nada in the Department of Histopathology. So this is Dr. Ritambra, my institute, and I was fortunate enough to be with among the doyens of renal pathology, Dr. Ritambra, and I can see Dr. Mahesha here also, who is in this meeting today. And I sincerely thank my institute, AIIMS Bhubaneswar, my colleague and partner renal pathologist, Dr. Suvradeep Mitra, my nephrologist, Dr. Sandeep Panda, and my faculty members, rest of the faculty members, my technical staff, and my dear residents. So today, the topics in which I need to discuss the whole seminar is normal histology. I will briefly talk about the glomerular histology, especially the glomerular filtration barrier. Then I will discuss the terminologies that you come across very commonly when you open any renal pathology book. And the last 2 things are the handling of a renal biopsy and a reporting of a renal biopsy. So first of all, normal histology. So all of you obviously can understand this to be a glomerulus. For the postgraduates especially, I must tell you that in your practice, majority of the times you will find the cases with glomerular pathology. However, you can also find interstitial and tubular pathology as well as vascular pathology. When we report a renal biopsy, we dominantly see the renal biopsies in 3 compartments, namely the glomerulus, the tubulointerstitium, and the vessel. So I will concentrate more on glomerulus in the kidney biopsy because that's more important, or practically more important from your point of view. So in glomerulus, as you can see, this is the glomerular structure. In this photograph, I couldn't bring the two poles of glomerulus, which are the vascular pole and the tubal pole. The vascular pole is the area where the afferent arteriole enter the glomerulus and the efferent arteriole emerges. So this is the point of attachment of a glomerulus. Exactly opposite or diagonally opposite to this vascular pole is the tubal pole, where the urinary space, this is the urinary space or the Bowman space, continue as the proximal convoluted tubule. So these are the vascular and the tubal pole.
Can I just break you for a minute? If you could
Yeah.
just change your pointer. Sorry for interrupting.
Yeah. Sure, sir. Yeah. Thank you, sir. Yeah. I just change it. Yeah.
And
Thank you.
another thing I would like to tell you is that your voice is going up and down a bit. So sometimes
Okay.
you are very clearly audible and sometimes you're not very clearly audible. That's it. Sorry
Right.
for interrupting. Sorry.
No problem, sir. Thank you, sir. Okay. Am I audible, sir, now? Is it better? Hello? Yeah. Am I audible, sir?
Yeah, you're audible. Yeah, you're audible.
Yeah.
Clearly.
Okay. Right. So just now I have described two poles. One is the vascular pole, another is the tubal pole. So they usually stay kind of opposite to each other. The vascular pole is the one where the arteriole, afferent arteriole enters the glomerulus and the efferent arteriole emerges out of it, and the tubal pole is the one where the urinary space continues as proximal convoluted tubule. We have to remember these two areas because there are some pathology which are related to the vascular pole as well as the tubal pole. Especially, I think when Dr. Debashish will talk about focal segmental glomerulosclerosis, maybe next class, the importance of these two poles can be better highlighted. So now what you can see, the most important structure is the glomerular basement membrane. We tend to look at the glomerulus at the periphery of this particular field. I mean to say, do not try to assess the glomerular pathology at the center of the glomerulus. Most of the times you'll be mistaken. However, look at the periphery for the first thing that we usually look into in terms of glomerular pathology, that whether the glomerular basement membrane is thickened or not. So the easiest way to do that is, especially in PAA stain, this is the hematoxylin and eosin stain. In PAA stain, try to assess the thickness or compare the thickness of a glomerular basement membrane with the thickness of a tubular basement membrane, and the tubule has to be non-atrophic. So if the thickness are comparable, then the glomerular basement membrane is not thickened, it's of normal thickness. That's the rough estimation that we do. The second thing that we have to understand very clearly is the visceral podocyte. You can easily see the nucleus of a cell here, which is kind of flattened and lying at the top of the glomerular capillary loop or the glomerular basement membrane. We call it a visceral epithelial cell or a visceral podocyte. Naturally, there has to be a podocyte or an epithelial cell which is parietal. So this is the visceral epithelial cell or visceral podocyte, whereas this one, this flattened cell just opposed to the Bowman's capsule, this is the Bowman's capsule, you can see this Bowman's capsule nicely. These flattened cells are known as the parietal podocytes or parietal epithelial cell. The next most important structure in the glomerular pathology is the endothelial cell. You can see nicely the endothelial cell. Unlike the visceral podocyte, they lie inside the glomerular capillary loop. So the podocyte lies at the top of it and the endothelial cell lies within the capillary loop. The next most important structure is the mesangial cell or as well as the mesangial matrix. So if you look at the area where the capillary loops are forming a U, two consecutive capillary loops are joining and forming a U, and there is a little bit of eosinophilic material with some cell nuclei, this is called the mesangium. and there are some nuclei within this mesangial matrix which are known as mesangial cells. Normally we tend to have 1 to 3 mesangial cells per mesangial area. Any increase in the number will be termed as mesangial hypercellularity, also known as mesangioproliferation. Now I have already shown you this Bowman's capsule. And lastly, the parietal podocytes or the parietal epithelial cell. I just want to tell you that unlike visceral podocyte, the parietal podocytes and parietal epithelial cells are not entirely the same things. For theoretical purpose, a parietal epithelial cell are these cells which are lying the Bowman's capsule, whereas a parietal podocyte is the cell which kind of connects the Bowman's capsule with the glomerular basement membrane, which means it has the property of both a parietal epithelial cell as well as the visceral podocyte. So it stays somewhere in between and emanates its food processes towards the Bowman's capsule as well as to the over the glomerular basement membrane. So these are called parietal podocytes. It's important to know because people believe that the crescents actually emerge from the parietal podocytes rather than from the parietal epithelial cells. Although in common parlance, we tend to say that crescent is the proliferation of the parietal epithelial cells. So sometimes we interchangeably use parietal podocytes and parietal epithelial cells, but for theory purpose, you should know that they are not entirely similar cells. The last thing that you should know in this glomerular morphology is the urinary space, also known as the Bowman space, which is continued as proximal convoluted tubule at the tubal pole. Now, I would like to show you the electron microscopy of the same glomerulus. So I don't know whether you are already acquainted with looking at the electron microscopy. I'm considering that you are not. So just try to see that this particular black thread-like structure, which I am just tracing now, is the glomerular basement membrane, right? And here it is forming a glomerular capillary loop, just similar to this kind of glomerular capillary loop, this kind of rounded structure. If I trace it from here to here, that magnification I am showing here in electron microscopy, right? Underneath this, inside this black colored glomerular basement membrane, you can see one nucleus, two nucleus. So these are the nuclei of the endothelial cell. Whereas just overlying it, you can also see nucleus of another cell. So this should be the visceral podocyte. So these are the two most important cells. So this is the visceral podocyte, this is the endothelial cell, and this is the glomerular basement membrane. Now try to look at the waist of glomerular basement membrane, which is known as paramesangium or glomerular waist, and at this particular area you can see that there is some black colored material which is as electron dense as glomerular basement membrane, and this is the mesangial matrix. In this particular cut you cannot see the nucleus of a mesangium, but in some other cut or in some other area you should see the mesangial cell. So this is the mesangium and this is the paramesangial area. Now if you look at the podocyte, the visceral podocyte, you can see only the nucleus, and rest of the cell body you can see this kind of fluffy structures. This is the cell body of the visceral podocyte. Now you can see another nucleus of a visceral podocyte just adjacent to this one, and this is the cell body of the visceral podocytes. Now if you carefully look, there are some structures, some thin thread-like structures. Can you see these structures which are just lying on top of the glomerular basement membranes, and these are the food processes. In a visceral podocyte you can have different levels of food processes, the primary, the secondary and the tertiary food processes, and they stay over the glomerular basement membrane, just like food process. So they are termed as food processes, right? I will try to depict this once again in higher magnification as well. So this is the glomerular basement membrane, the visceral podocyte, the endothelial cells, and the mesangium, especially the mesangial matrix is seen here. So this is the higher magnification. Now try to look at the glomerular basement membrane. This is the glomerular basement membrane. And now the glomerular basement membrane is usually trilaminar, which means you can see clearly three levels. Usually, the most intermediate layer of glomerular basement membrane is thicker or denser or more electron dense than the rest two. So this dense region is known as lamina densa. The other two layers just above and below or inside and outside the lamina densa are known as lamina rara, because this is rarefied or thinner in terms of electron density. So just because they are inner and outer, so they are known as lamina rara externa, which is towards the podocyte surface, and lamina rara interna, which is towards the endothelial surface. Of course, you can see the endothelial cell nucleus, at least the part of it. And if you look at the cytoplasm of the endothelial cell, it's not very well visualized because there is usually very scant amount of cytoplasm of the endothelial cell. And when it swells up, we term it as endotheliosis. But if you look very closely to this particular electron microscopic picture, you can see that I'll also show the higher magnification. So you can also see that there is a little thinner kind of layer which have some fenestrations or gaps in it. I will discuss this, which are known as endothelial fenestrae. And now also these are the food processes. Can you understand the food process like hip-like arrangements of these food processes? Obviously, this umbrella-like thing is the cell body of the visceral podocyte. Now, I would like to talk a little bit about glomerular filtration barrier. It is formed of fenestrated endothelial cells. I will show it in higher magnification. Each of the fenestrum or each of the gap measuring approximately 60 to 100 nanometer. Then there is glomerular basement membrane, which I have told that it has three layers: the lamina rara interna, lamina densa, followed by lamina rara externa towards the podocytic surface. Then comes the podocytes with interdigitating food processes and filtration slates. I will describe what a filtration slate is. And there are two newly described layers which are known as endothelial cell surface layer or ESL and subpodocyte space or SPS, which actually forms 60% of the filtration area. So obviously from the previous electron microscopy, you can easily understand the endothelial fenestrae, you can understand the glomerular basement membrane, and you can also understand the food processes. I will describe the other two layers in detail now. So this is kind of a very high resolution photograph in which you can see that this is the endothelial cells, and this is the gap in the cytoplasm of the endothelial cell. These are known as fenestrum, which measures approximately 60 to 100 nanometer. Now, after that, if you look at this glomerular basement membrane, you can see that the middle layer is very dense, which is the lamina densa, and just the layer above and below are rarefied or thinner in terms of electron density. So they are termed as lamina rara, externa and interna. These are the food processes which you can clearly see. Now, if you look at the endothelial cell, there is a very thin layer which is not even visible in this magnification, which is usually formed of the proteoglycans and secreted material, which forms, and glycocalyx of course, which forms a thin layer but a very important layer in terms of glomerular filtration barrier, known as endothelial surface layer, or ESL. This is the kind of layer that you can see. It requires a lot of high technology to detect this particular layer. But this space is quite easily visible, and you can see it even in this magnification. You see that these are the food processes, and just above this, these are the part of the cell body. So this area forms the subpodocyte space. Previously, it was thought that the subpodocyte space is just a space where the urine is accumulated, but it has been found that the subpodocyte space is not constant and is rather dynamic. So it actually functionally regulate the formation of urine and the formation of amount of urine. And people have also demonstrated the subpodocyte space, and actually there lies an exit pores which the podocyte in terms of contraction and expansion can regulate the formation of this exit pore. It can close it, it can open it, etc. So it's a quite advanced thing. I don't want to go into detail of it, but I have given the reference. If you want to read about it, you can of course read about it. So now I'll talk about the glomerular basement membrane. It's a very unique membrane. You should know the thickness of glomerular basement membrane, which is approximately 300 to 350 nanometer. And the uniqueness is it's much more thickened than any other basement membrane in the body, because it apparently it is formed by the sandwiching of two basement membrane. That's why the intermediate layer of the glomerular basement membrane is dense and forms the lamina densa, and that's why it is much thicker than the basement membrane elsewhere in the body. Also, the glomerular basement membrane is a very important part in the glomerular filtration barrier, and it is usually secreted as well as maintained by the visceral podocytes. So again, this is the electron microscopic photograph, just to highlight how the podocyte food process looks like. This is the subpodocyte space. You can see the nice lamina densa here, lamina rara externa, lamina rara interna here, the endothelial cell cytoplasm. You can see the cytoplasmic subcellular organelles. This is the fenestrum, or the gap between this endothelial cell cytoplasm, and a thicker kind of blackish kind of area which is known as the endothelial surface layer. So in terms of glomerular filtration barrier, you have these 5 layers. Now I would like to draw your attention to something called filtration slit or slit diaphragm, etc. So let me tell you that this filtration slit lies somewhere here, just at the bottom end of the food processes. So let me show you. So this is a very nice article which came out in NEJM by Tryggvason et al. And you can see that so the previous, these are the electron microscopy. This is known as transmission electron microscopy, whereas this is a scanning electron microscopy picture. It doesn't go through the tissue, but scans the surface area and give the picture in 3 dimensions. So now you can understand this is the cell body of a food process. Can you see this? And these are the food processes which are emanating from the cell body, and this is the schematic diagram. You can see the food process which have entwined the glomerular basement membrane, giving up their food processes which are dividing primary, secondary, tertiary, and then forming this kind of very interdigitating structure just over the glomerular basement membrane. And if you go in deeper detail, these are the food processes, and this article have mentioned that they have this area is even smaller. They are more compressed, but they have separated purposefully just to show you how the filtration diaphragm looks like. And this stays somewhere here. If you see this in between the food processes, this filtration diaphragm or slit diaphragm stay interdigitated. I will show in greater detail. So this schematic diagram is also taken from the same article. If you see that this is the food process of the visceral podocytes, and this is the filtration diaphragm. There are a lot of proteins which interdigitate with each other, forming the effective glomerular filtration barrier, which is both charge barrier as well as size barrier. And in this picture, they have actually put a molecule just similar size of that of albumin, just to show the comparison between albumin and the slit which is there. So if you can see that the albumin molecule is comparable to the slit of the slit diaphragm. However, there is a charge barrier because of which the albumin cannot really come out of the glomerular filtration barrier. And also in this schematic three-dimensional 3D reconstruction image, they have shown that the central part of the slit diaphragm is more compact, whereas it's the peripheral part which is a kind of porous, allowing the urine to form or the plasma to be filtrated. Uh, in this filtration diaphragm or the slit diaphragm, you can see names of a lot of proteins. Of course, you are quite acquainted with the names of at least these two proteins, nephrin and podocin, the mutation of which gives rise to congenital nephrotic syndrome phenotype in the mutation of nephrin. So infantile nephrotic syndrome can be caused by the mutation of nephrin and podocin, and even the mutation of this kind of proteins. So this is the importance of the proteins in the filtration diaphragm. Other than the filtration diaphragm, which looks like this, there are a lot of other molecules which maintain the integrity of the podocyte as well as the podocyte food processes. So these proteins are also linked to the actin molecules. These are the actin molecules inside the food processes. I already told you about the pores, the subpodocyte exit pores in one of the previous photos. This is the exit pore. I told you that this is dynamically regulated, and how? Because you see that the slit diaphragm is also linked to the actin molecule. So depending on the requirement, depending on different functional status, it can also regulate the contraction of this actin molecule, thereby contracting the podocyte foot processes and controlling the formation of urine, controlling the pore size of the SPS exit. And so it's a kind of a dynamic process. So other than the slit diaphragm, which I am stressing on, there are also proteins which stay in the apical membrane of the visceral podocyte, namely podocalyxin, podoflanin, podoandin, and so many, as well as the basal domain proteins, which are mainly the integrins as well as dystroglycan proteins, which are also important for the integrity of a visceral podocyte. And these are the different protein molecules: nephrin, neph1, neph2, FAT1, ZO1, CD2AP, etc. At least you remember names of these two proteins, nephrin and podocin, for the integral maintenance of the slit diaphragm. Other than that, there are a lot of structural proteins in the form of collagen, laminin, egrin, and nidogen. And I'm not going into detail of the structural protein, but just remember that it's the collagen type 4 which remains in the glomerular basement membrane. So with that, I would like to discuss a little bit of terminologies that you come across very regularly during reading the renal pathology. The first thing, which when we look at whenever we look at any histopathology biopsy and renal biopsy as well, we look at it in low magnification and try to assess that whether the pathology is something which is present in almost every glomerulus, or is it some pathology which is present in one or two or a few glomerulus. So there is a definition. So here in this photograph, you can see that the pathology is involving almost every glomerulus, and that the pathology is in the form of thickening of the glomerular basement membrane. By just the way what I said, you take a tubule which is non-atrophic, compare the thickness of tubular basement membrane with the thickness of glomerular basement membrane. It may be very subtle for the beginners, but for a practiced eye, people can easily tell that the glomerular basement membrane is globally thickened, as well as there is stiffening of the glomerular capillary loops, and it is kind of involving all the glomeruli. So it's a diffuse process. So definition wise, if the disease involves more than 50% of the glomeruli, it's a diffuse process. So how do you calculate this 50%? You get a core. Usually we get a core biopsy in kidney. You count the number of glomeruli. Maybe there are 11 glomeruli, and this is the disease process which is involving almost 8 of the glomeruli. So it's a diffuse process because it's more than 50%. And then if you look at this particular biopsy, this is the glomerulus which is showing some pathology, whereas other glomeruli are kind of normal in terms of light microscopy. So if we have only 4 glomeruli in this core and only one glomerulus is showing some pathology, then it's considered to be a focal lesion. Definition wise, it is less than 50% of the glomerular pathology. I mean, in the core, if less than 50% glomerulus is involved by the pathology. This is one photograph just to show you practically how it looks like. It's a silver stain. You count the number of glomerulus 1, 2, 3, 4, 5, 6, and like that. And these are all globally sclerosed glomerulus. So it's easy, even in this low magnification, to ascertain that whether the pathology is involving more than 50% glomeruli or not. And then you can comment whether the disease is a global disease or a focal disease. So now once you have decided whether the disease is involving more than 50% of the glomeruli or less than 50%, you look at individual glomerulus, whether the disease is um, involving more than 50% of the circumference, or it is involving less than 50% of the circumference. Again, in this particular glomerulus, the basement membrane is thickened involving the whole circumference. So it's a global disease. So if you come back to this particular photograph, this is involving all the glomeruli, and it is involving the whole circumference of all the glomeruli. So it's a diffuse and global disease. Whereas if you look at this glomerulus, this part of the glomerulus is normal, whereas this area is pathological in terms of sclerosis, and there is some podocyte proliferation, visceral podocyte proliferation. So this is something known as a focal lesion because it is involving less than 50% of the circumference. Now, I already told you about the tubal pole and the vascular pole at the beginning of my lecture, and you can see that here the Bowman space or the urinary space is being continued as the proximal convoluted tubule. So this particular area is known as the tubal pole, and there is a lesion at the tubal pole. So I think Dr. Debashish will talk about this. This is actually a tip lesion of focal segmental glomerulosclerosis. So now I will talk about the proliferative lesions. Let us see. If you look at now I told you that in the mesangium, the normal number of nuclei that you tend to see is 1, 2, 3. Now, if you count in the mesangium, the number of nuclei which have surrounding mesangial matrix is more than 3 in all these areas, isn't it? So this is known as something as mesangial hypercellularity. In books, you will find also the terminology as mesangial proliferation. It is kind of similar to mesangial hypercellularity, but the terminology of mesangial proliferation now is gradually being replaced by mesangial hypercellularity. The reason being, proliferation usually denotes the proliferation of a particular lineage. However, hypercellularity means that the number of cells is more. So if in mesangial proliferative diseases, you tend to see the hypercellularity of the mesangial cells, as well as there can be infiltrating leukocytes like neutrophils or monocyte macrophages. Also, there can be endothelial cell interposition. So you do not want to label it as only mesangial proliferation, which denotes essentially that the mesangial cells have grown up in number. However, mesangial hypercellularity means that all types of cells have kind of increased in number inside the mesangial matrix. Similarly, endocapillary proliferation has also been kind of replaced by endocapillary hypercellularity terminology. The reason is quite clear because you can see that the endothelial cells, the mesangial cells, the infiltrating leukocytes all have increased in number. The one of the best ways to identify endocapillary hypercellularity is at the periphery. I told you to look at the periphery of the lesions, and you can see when you see that the capillary loops are not visible. You see here the capillary loops are quite nicely visible, and only the mesangium is hypercellular, whereas if you look here you cannot see the capillary loops at the periphery, and you can safely say that this is a situation of endocapillary hypercellularity. Also, I would like to draw your attention to another thing. If you look at this particular glomerulus, you cannot see lobules. I can vaguely draw lines of lobules, but whereas when you see this particular glomerulus, you can see nice club-shaped structure which are known as the glomerular lobules, and this particular feature is known as lobular accentuation. Also, you can see the types of cells which have infiltrated. You can see the neutrophils here and there, and also if you look closely you can see that there are nice nuclear debris which are this material nuclear dust material, which are known as karyorectic debris in the glomerular pathology. This is to show you how a glomerular basement membrane split looks like in light microscope. You can see that this is the endothelial cell, and you can see a very nice split here. Also, you can see the split here and different other areas like here. Unlike this one, I can show you this one, which is nice and normal in morphology. So this is known as glomerular basement membrane split, and you can also obviously identify the endocapillary hypercellularity in these areas. You should also recognize one of the most important proliferative lesion, which is known as crescent. You can see why it is called crescent, because it is semilunar in shape. The current definition, which we will discuss, Dr. Debashish will discuss in some other class. Nowadays, you do not need the whole circumference of proliferation of parietal epithelial cells to call it a crescent. Just 10% of the circumference will do, especially in cases of SLE, and this is known as the crescent, which is basically the proliferation of parietal epithelial cells within the urinary space, and the thickness of the cells are more than 2 cell layer thick. And this is what I wanted to tell about the thickening of the glomerular basement membrane. So whatever pathology or terminology I have shown till now, we can divide it roughly into proliferative lesions and non-proliferative lesions. In this pathology, which I told you as steep lesion of FSGS, there is no significant cellular proliferation, so we call it a non-proliferative lesion. Similarly, in minimal change disease, where the glomerulus looks exactly normal, is a non-proliferative lesion. You can see this global thickening of glomerular basement membrane, which can occur in diabetes, which can also occur in membranous nephropathy, which is also a non-proliferative type of lesion. And when we talk about proliferation, this could be an intracapillary or an extracapillary. Extracapillary is crescent, intracapillary or endocapillary, and mesangial kind of proliferation. So based on this, we can divide the glomerular pathology into proliferative and non-proliferative glomerular diseases, which we will discuss in our subsequent classes. The reason why we tend to divide it into non-proliferative pathology and proliferative pathology is that although it's not really watertight, but in proliferative lesions, the patients tend to present with nephritic feature or a combination of nephrotic and nephritic feature. We'll discuss that in our subsequent classes. Whereas in when we see a non-proliferative pathology like minimal change disease or FSGS or MGN, that is membranous glomerulonephritis, the patients usually present with more degree of proteinuria or nephrotic syndrome. Usually a proliferative lesion presenting with nephrotic syndrome, it can occur of course, but it's kind of less common. So looking at the glomerular pathology, we can also kind of predict or kind of assess that what kind of presentation could it be. Other than that, other than these nephrotic or nephritic kind of features, we can also have renal failure like rapidly progressive renal failure or azotemia or uremia. The patients can present simply with a rise in serum creatinine. Hypertension could be one feature, which is the classical feature of nephritic syndrome. Also hematuria without anything, I mean isolated hematuria could also be the clinical presentation. There are many other clinical presentation, but this is just a brief of how the patients present to us. Of course, you know about nephrotic syndrome. It presents with massive proteinuria followed by hypoalbuminemia and anasarca, which is generalized edema, also associated with dyslipidemia and lipiduria. And in terms of complication, because there is loss of lot of proteins, including the globulins, which are immunoglobulins, the patients become prone to infection because they also tend to lose a lot of antithrombotic proteins like so the patients are also prone to renal vein thrombosis. So these are the complications of nephrotic syndrome. Now, whatever histomorphology, or I have discussed the histomorphology of glomerular basement membrane and the slit diaphragm, the glomerular filtration barrier. So till now we have understood that podocytes, or rather the visceral podocytes, form one of the most important, one of the most pivotal role in determining the pathology of glomerular diseases. So all this pathology comes under the umbrella of podocytopathy. Remember that the podocytopathy does not only include minimal change disease or FSGS or MGN, but essentially any disease which causes disruption of the glomerular filtration barrier is actually a podocytopathy, because it causes some degree of injury and some degree of functional failure to the visceral podocyte. So definition wise, it is a qualitative or a quantitative diminution, usually due to an external or internal stress injury, because of a structural or functional defect, and morphologically in terms of electron microscopy it is visualized as food process effacement, which means flattening of the food processes. So this is you can read up a very extensive article by Laura Barisoni in which the podocyte injury, she has kind of classified it in terms of the number of podocyte. Usually I say that there is quantitative or qualitative diminution, but here you can see that there is podocyte proliferation. So how does it kind of how my definition is similar, because here although there is quantitative proliferation, but there is qualitative diminution or qualitative defect. So looking at the number of podocytes, you can also decide which type of podocytopathy is there. Usually in minimal change disease, there is no change in podocyte number, whereas FSGS is typically demonstrated by podocyte detachment or death and a number of podocyte count, which is also known as podocytopenia. And if there is podocytic proliferation, it usually occurs in diffuse mesangial sclerosis and collapsing glomerulopathy. In collapsing glomerulopathy, the count is usually very high. There is good number of podocyte proliferation and crowning by the podocytes. So now I'll discuss a little bit about the handling of a renal biopsy. So if we usually the renal biopsy comes in three cores, especially in the institutes where the facilities are available. One core is for the light microscopic examination, one core is for the direct immunofluorescence, which is a mandatory thing, and the third core is for electron microscopy. Obviously, electron microscopy facility is not available in every center, so at least two cores are favorable. And if you find these two cores, you can also divide it like this for light microscopy, and one part for direct immunofluorescence and one part for electron microscopy. If you do not find three cores, if the clinician has not taken three cores, sometimes it becomes really problematic for the clinician to take more than one core, and at that time the clinician ideally calls you up and says that there is only one core that he or she could obtain, and at that time you need to divide the core into at least for light microscopy and electron microscopy, sometime light microscopy and direct immunofluorescence, and depending on the diagnosis you also kind of tend to preserve a little bit for electron microscopy, but light microscopy and direct immunofluorescence are the bare minimum requisite for interpretation of a renal biopsy. So when we get just one core and you do not have any core for direct immunofluorescence and or electron microscopy, what do? Ideally, you should have a dissecting microscope or a stereo microscope under which you can look at the core biopsy, and you can find out that which area is the glomerulus. You can divide it underneath the microscope and submit one part for the electron microscopy and one part for the light microscopy. But all institutes, including our institute, currently do not have the facility for a dissecting microscope. So sometimes we just take help of our light microscope. We just mount the core underneath on a slide, just a fresh mount. And glomerulus is usually visible in the lowest magnification as a bloodless or sometimes a bloodless structure, and you can sometimes see a little bit of bulge where the glomerulus stays. And here you can also see the medulla nicely. You can see the striations, the medullary cord. So if I have to divide this particular core, I will divide at a portion so that I can have a tissue for both direct immunofluorescence as well as for light microscopic examination. So this is the glomerulus. This is the part of renal cortex which I can nicely identify, and this is the renal medulla. So when we look at the renal biopsy, we tend to stain it for four stains. Other than the hematoxylin and eosin stain, which is the routine stain, at least you should have one PA stain. It's extremely essential to have a PA stain as well as a Masson trichrome stain. It's really good if you can have a silver stain in terms of methenamine silver, usually Jones methenamine silver, and this is how the cores look like in the low magnification. So why I'm stressing upon the PA stain and not on HE stain? Usually the renal pathologist look at the PA stain rather than the hematoxylin and eosin stain, because this is the one of the best stains to look at the glomerular basement membrane. Do not really try to assess the glomerular basement membrane in hematoxylin and eosin stain, because it often gives a false kind of impression of thickening. But look at the glomerular basement membrane in PA stain, which is nice, and here you can compare this basement membrane with the tubular basement membrane, and you can see that there is global thickening of the glomerular basement membrane. Also, different other structures are very nicely visualized in PA stain, majority of the structure, but the most important is the glomerular basement membrane. The Masson trichrome stain is mostly used for two very important purposes. There are other purposes as well. I'm just highlighting the major purpose. One is for assessment of this interstitial fibrosis. You can see the blue areas, which are the fibrosed areas, followed by along with the tubular atrophy. So This is something known as interstitial fibrosis tubular atrophy, which is in short, it is called IFTA. IFTA in any disease pathology, even though it's a glomerular pathology, IFTA usually correlates very well with the clinical feature and the disease progression. So if you see more than 50% IFTA in a particular renal core, you alert the clinician that probably the disease is already quite advanced and probably the drug is not going to help very much. However, if you find the IFTA is kind of 20% or 15%, 30%, you can still say the clinician that yes, you can have a nice trial with immunosuppressive agents and corticosteroids like that. The other nice feature of Masson trichrome stain is this. If you look at the glomerular basement membrane, it's blue stained in Masson trichrome. And can you see this nice functionophilic or red colored globules? These are the immunoglobulin deposits in Masson trichrome stain. So the immunoglobulins take up nicely the fuchsin color of Masson trichrome in contrast to the basement membrane, and it's often a very helpful feature if you do not have the facility of direct immunofluorescence and others. Obviously, silver stain is one of the best stains to look at the basement membrane. You can assess the basement membrane nicely. The counter stain used in Jones methenamine silver is usually hematoxylin and eosin, but we can also do it do the light green counter stain. In our institute we do both, and the results are really superb. Hematoxylin and eosin stain in renal biopsy is done for some, I mean, it is done routinely, but some specific features are easily taken up by hematoxylin and eosin stain. I already said that please do not interpret the glomerular basement membrane thickness in hematoxylin and eosin. You can look at different crystals like calcium crystals or oxalate crystals in hematoxylin and eosin. This is a case of C3 glomerulopathy, in fact dense deposit disease, where the nicely red refractile structures are actually the deposits of the complement deposits of dense deposit disease DDD. So that kind of structures are nicely highlighted by hematoxylin and eosin. If you have amyloid, it often gives a clue better in hematoxylin and eosin stain. There are other features like you can assess the vascular morphology nicely in hematoxylin and eosin. Other stains which are commonly used in renal pathology is of course Congo red stain, which is used for demonstration of amyloid. You can see nice apple green birefringence under polarizer and analyzer. So this is the bare minimum for a renal pathologist. Also an elastic stain, namely the elastic Van Gieson, which is commonly used for the assessment of the vascular structures, are also used. And if you have the stains for fibrin, that's very good. It's really helpful. Marcia scarlet blue or MSB stain is a very good stain. It's very crisp. You can see the fibrin in different stages. These are the RBCs which are yellow. This is the fresh fibrin, and when the fibrin becomes organized, in the case of thrombotic microangiopathy, if the fibrin becomes organized, it will give you a bluish color. Also phosphotungstic acid hematoxylin, which is also a fibrin stain, but it doesn't have the ability to discern different stages of fibrin. So now after this light microscopy, all the renal biopsies should be subjected to direct immunofluorescence. Usually there are three heavy chains, 2 light chains and 2 complements which we performed in all renal biopsies. Nowadays also C4D is kind of becoming very familiar. Other than transplant biopsies, also people prefer to do a C4D even in the routine panel in terms of direct immunofluorescence or immunohistochemistry. I must emphasize that direct immunofluorescence is a much more sensitive technique than immunohistochemistry for this particular stains. So other than these heavy chains, what is the importance of these 2 complements? Because C3 is the denotes the common complement pathway. C1q is the representative of the classical complement pathway from which it starts, and C4 is the representative of the alternate or of the lectin based pathway. So if you have all these complements in your repertoire, then you can obviously interpret that which pathway is proactive in causing this glomerular disease. In addition, sometimes in some specific cases, we tend to take help of fibrinogen and albumin in terms of direct immunofluorescence. This particular is a case of membranous glomerulopathy, and you can see nice, very fine, uniformly granular deposit along the basement membrane. I don't know whether you can appreciate the fine granularity in this, but if you look closely and train your eyes, for the postgraduates especially, then you can identify this. Immunohistochemistry in renal pathology is used in only some cases, especially in transplant biopsy. C4D is often used as an IHC as well as in direct immunofluorescence. SV40, this is the SV40 IHC, which is used for polyomavirus nephropathy, which is also commonly used in transplant biopsy. In amyloidosis, we use SAA, serum amyloid A protein, as immunohistochemistry, etc. Now, these are other than this, light microscopy and direct immunofluorescence, I told you that ideally all the renal biopsies should have electron microscopic examination. So before electron microscopic examination, we tend to assess that whether the core which has been sent for electron microscopic examination is adequate or not, whether the area of interest is there or not, and if there is, then which area we need to focus on. So for that, we need to cut the core sent for electron microscopy into a semi-thin section. This is a semi-thin section which is stained by toluidine blue and is mounted on epoxy resin. It is often used to assess the adequacy or the area of interest in electron microscopy. However, I must emphasize that a semi-thin section often gives you very important clue about disease pathogenesis which are not kind of highlighted even in light microscopy or direct immunofluorescence. Especially subtle immune complex depositions and other pathology can be very nicely highlighted in semi-thin section. So it does not only have the assessment kind of value, but also sometimes it can have diagnostic value. Obviously, the last thing in interpreting a renal biopsy is the transmission electron microscopy. We do not use a lot of scanning electron microscopy. The problem with this particular modality is it's not widely available, but if it is available, you can see a lot of things and correlate with light microscopy and direct immunofluorescence, and often you can also add up to it. Sometimes you are not sure about a diagnosis in terms of light microscopy or direct immunofluorescence. Especially there are some renal diseases for which electron microscopy is a mandate, like thin basement membrane disease that I can remember. Also Alport syndrome, although immunofluorescence is available for Alport syndrome, but looking at the transmission electron microscopy is really very helpful. So there are, and even in the immune complex deposition diseases, amyloidosis, different organized deposition disease, transmission electron microscopy is a real mandate. Sometimes, for example, if you have immunotactoid glomerulopathy or fibrillary glomerulopathy, without the help of electron microscopy, you really cannot diagnose these cases. And this is one electron microscopy from an immune complex disease. You can see the nice glomerular basement membrane and this blackish colored smudges just underneath the glomerular basement membrane. So these are the sub-endothelial deposits. So I should say that there are three areas in immune complex diseases where you should look for the electron dense immune complex deposits. They are the subendothelial, which means in between the endothelium and the glomerular basement membrane. intramembranous, which means inside the glomerular basement membrane, and subepithelium. That means in between the podocyte foot process and the glomerular basement membrane. And lastly, the people who practice renal pathology, they tend to um, uh, send this kind of forms for to the clinicians. It is kind of different from institute to institute, but they tend to have similar kind of information that we seek from the clinician from for a proper interpretation. Other than the clinical features, you want to know the exact level of serum creatinine, the creatinine clearance, the proteinuria level, the urine sediment, total protein and serum albumin. You obviously want to know the ANA ANCA status of the patient, the complement, whether there is any deficiency or hypocomplementemia. Also, majority of the time we want to know the HIV, Hep B and Hep C status, all of which can predispose to different renal diseases. So with this, I end my topic. Please, this is Coppersmith Barbet, which I have clicked just in front of AIIMS Bhubaneswar. So this is a very beautiful bird. If you come to AIIMS Bhubaneswar, you can have such nice birds, as well as you can see a lot of cases. So with this, I open this session for receiving all kind of blows.
Thank you, Dr. Suvradeep. So excellently and so nicely you have explained the basic aspect. Now I would like people who would like to ask some questions. Anybody or any comment? Please, you can unmute your mic and just ask any question or any comment.
Hello.
Yes, please.
Hello. Yeah. For the crescent formation, which is the best stent that we can use? Sometimes the crescent formation, it is very difficult when there is no fibrous area. The cellular crescent sometimes is very difficult. So, which stent do you prefer?
So, sir, I tend to see, there is nothing called the best end, but I feel that PAS and Mason trichrome is very helpful other than HE. HE can give you the idea, but PAS and Mason trichrome is a very good stain. In addition, if you have the provision of silver stain, it can actually give you the nice outline of the glomerular basement membrane, and sometimes you can see nice rupture of the glomerular basement membrane for demonstration of the crescent, which is really, really helpful. I think there is nothing best, but you have to look into it in all kinds of stents.
Silver stent is better. Silver stent can bring out.
Yeah. I think Dr. Mahesha is also there. If he wants to add anything, he is a doyen of renal pathology, and he is really a king of renal pathology. If he can also address and expand our knowledge, Dr. Mahesha, who is my senior.
Dr. Subro, thanks for your lecture. It was excellent to hear your voice, and the content of the presentation was too good.
Thank you, sir.
Loved it. One point in the histology slides is quite often there would be a difficulty in identifying the sclerosis versus the necrotizing lesion. I guess in the next class it would be taken.
Yeah.
I mean, there's nothing to add, Dr. Suru. You have
No.
entirely.
Thank you.
Anybody else would like to ask? There are quite a few comments which I would like to read it for you. Dr. Mahesha, excellent lecture, Dr. Suvradeep.
Thank you, sir.
Is nice presentation, Dr. Suvradeep. Dr.
Okay,
Bharati says, congratulations, Dr. Suvradeep, very useful one for beginners. Thank you for the wonderful presentation. Madhusmita Sethi says, excellent lecture. Thank you very much, Dr. Subhudeep. Shilpi Thakur says, felt like a junior resident once again. Thank you.
Oh, that's so sweet. Thank you.
Yeah. Anybody else would like to pass any comment, or anybody would like to ask any specific question? Yeah, I think there are none. So I would like to thank Dr. Shubhadeep for a wonderful lecture. Let me tell you one thing, that the depth of knowledge is very clearly visible by the simplicity in explanation of things. That explains how deeply you know the subject, because it's like the eagle's eye in trying to look at everything. Thank you so much, Dr. Subhidi, for taking out time from your busy schedule and trying to teach us the basics of nephropathology. And I think you have 2 more lectures to take. That will be the next Wednesday and the Wednesday following that. And this Friday we have Dr. Debashish Gutscheit, who is an associate professor in JIPMER, who will be taking a lecture on renal pathology. So please join in, everybody. Thank you so much. God bless you. Bye-bye.
Thank you, sir. Thank you, sir. Good night. Bye, sir.
Bye. Good night. Bye.